The Northwest Law and Mental Health Conference brings together expert speakers with legal, clinical, and lived experience to discuss the impact of the law on people with mental illness and addiction. Our spring 2020 conference was postponed due to COVID-19, so presenters recorded their sessions, which are now embedded in the conference website along with their collateral information. Thanks to all our expert presenters, generous sponsors, exhibitors, volunteers, and the planning committee for the Northwest Law and Mental Health Conference. Stay well, and we hope to see you in 2021.
So, good afternoon, and thank you so much for joining us today. My name is Melissa Fisher. I'm not here today as a regional senior strategic marketing consultant for one of the nation's largest healthcare systems. I'm also not here speaking as the ambassador for Oregon for the Association of Frontotemporal Dementia, but I am here as the daughter of a father who's been diagnosed with this palliative neurological disease that's called frontotemporal dementia. This afternoon, I would like to share with you my family's story and the tragedy of this specific disease. And the reason why I brought it here to you is that last year I attended the Northwest Law and Mental Health Conference, and I was interested in learning more about the populations that are presented at this conference. I recognize that mental health and addiction are both very important populations, but I feel like one in particular has not been accounted for, and yet a lot of systems, organizations, systems, and individuals are accounted. So, what I want to share with you is that my dad was diagnosed with frontotemporal dementia in February of 2017. I assume that most of you have never heard of this disease or know anything about it. Today, my presenting partner, Dr. Bruce Miller, and I are going to talk about this, where I'm going to share the tragedy through our family story and also the research and clinical information that you would find useful in your work. 60 Minutes calls this the cruelest disease you've never heard of. And today, I hope that you find the opportunity to include this and consider this in your work. Thank you. Let's move on. So first thing I want to share with you is this picture. If we were meeting in person, I'd actually ask you from a show of hands to raise your hands. And as I challenged you to tell me, out of all these 8 individuals, how many of them here do you think have dementia? 1, 2, 3, perhaps 4, 5, 6. What if I told you that all 8 of the people in this picture have dementia? It's very interesting to think about dementia. Prior to my father's diagnosis, I thought of it as a disease of the aged and something specific to memory. I was utterly wrong. I lost my grandmother to Alzheimer's, but I had never heard of any other dementia prior to this. Everyone here in this photo ranges in a wide range of ages. It can strike you as early as in your 20s, your 30s, your 40s. My father was 70 years old when he was diagnosed, but it's likely based on symptoms that he's actually had this disease for the last 10 years. I want it to be clear that everyone's experience with this disease is different. It is not the same. But I am grateful to the families and the loved ones who shared these photos here today. They, like myself, want to see this message get out to the broader masses, and in particular, those of you who might be touching them in your work. I also want it to be clear that my family story is just that, my family's story. So everyone has a very unique experience with this disease. So I'm going to talk today about my dad. This is my family. My father on the right is Mark Moriarty. This was taken in Bend, Oregon 3 years ago in celebration of his 70th birthday. My dad was a brilliant, kind, generous, deeply devout, and loving husband for 51 years to my mother, and an incredible father and grandfather to 4. My dad was very adventurous. He owned a sailboat. He's extremely mechanical. He could build anything. He was a sailor, a stock car racer, and he owned a very successful custom home building business with my mom. He retired at the age of 49 to Maui, Hawaii. My age. I only wish I had been as capable as my dad was. My father was a great dad, but we started to see signs of something not right. They go back as far as 10 years. Early symptoms included excessive alcohol use, lack of interest in the things he formerly loved. He used to be extremely passionate about things, and all of a sudden he no longer was interested in those things. When he'd come to visit me, he used to look for home projects. He loved to help me in my home. On his visits in the last couple of years, he'd come, no interest in helping, and he would lay down and nap a lot on the couch. We'd have family events. My father would drink excessively. That wasn't like him. He was increasingly apathetic. He showed poor judgment. His social skills were deteriorating, and he was quite embarrassing at times in public. On the celebration of his 70th birthday, he actually licked his dinner plate and started to lick others' plates. I took it that it was the alcohol, but there was something more going on. He had the hyperfixations on things, pouring water for all of us. He would substitute words in favor of ones that he made up. He was easily agitated, increasingly rigid in his thinking, and he didn't have any care for laws or rules. To this day, my dad has no idea that there is anything wrong with him. I'm going to tell you a quick story to the extent of this disease. At one point, my father was out walking miles at a time, attempting to get alcohol because by then he didn't have his license anymore and he didn't have a vehicle. And he must have fallen at some point on his walk. He came home. My mom noted that his leg was quite swollen. She took him to the emergency room where they did an x-ray, and they discovered that he had a broken fibula. My dad did not believe that his fibula was broken. He was combative. He fought with the physician and the medical assistants and told them that if they attempted to put anything on his leg to heal it, he would take it off. He would cut through it. This is actually what was needed in order for my mom to obtain guardianship of my father. That's pretty significant, knowing that you don't even believe that you have a broken leg. And I'm going to take you back to one particular evening. The picture that you're going to see on the screen now is extremely disturbing. But this is an important picture because this is only, well, let's see, this was March on the left, this was December on the right of the same year. This was my father en route to the emergency room in the back of my sister's car. This is a very difficult story, but one that you need to hear because it's actually something that impacts a lot of you. One evening around December, I received a phone call from my father. Normally you would think that's a great thing to get a call from your dad. I didn't get that many calls anymore from him. But actually it was a very distressing call because my father had bailed himself out of jail. In a 3-month period of time, my father went to jail 6 times. He actually had abated arrest on several occasions, had gotten quite combative, and even so with my mom until they needed to put a restraining order against him. My dad had no idea what a restraining order was. He'd never heard of such a thing. So that night he called me. He had bailed himself out. My mom had not been notified that he had been bailed. And as a result of that, he had gone back to the house and had no way to get in and was calling me to find out if I knew how to get him in the house. My mom wasn't home at the time. And so I immediately told my dad I would call him back. And I would call my mom and I notified her to not return to the home. Now, I live in Oregon. My parents live in Hawaii. I somehow needed to get my dad somewhere safe and not in relationship to wherever my mom was. So I called him back and I told him to wait there and that I had a cab coming to get him. And I told him, you can't see mom. He's like, well, why? I said, because Dad, you have no way to see her right now. It would actually be against the law and you'd go back to jail. So he waited while I called the hotel and I made a reservation, and then I called a cab and I ordered a cab to come and get him. While the cab was en route, my father stayed on the phone with me. But when the cab finally arrived, as he was walking out to her, now mind you, he'd been drinking heavily, he fell. And as he fell, he split his head open. The cab driver on the phone with me told me she was not going to pick him up and left. Therein, I had to find another alternate route to get him somewhere. And the first place was the emergency room. My sister picked him up, took him to the emergency room, and while she was doing that, I was calling the aging services. I did an intake, and I had them meet my father at the hotel the following morning because I told them he was at risk and something needed to be done, and I wasn't getting anywhere with the police. And in fact, because he just kept going in and out of the courts, that wasn't working. I needed additional help. What happened is they told me that the social worker told me with her supervisor the next morning that there was nothing wrong with my father. That actually it was merely somebody who had an alcohol problem, and she put him on the phone and he promised that he would seek help for alcohol addiction. It was infuriating because I knew that my father was not well and that he had something more going on and it wasn't alcohol. But again, why would you assume that a man that looks like on the left actually has anything wrong with him other than potentially an alcohol addiction problem or a mental illness? So 6 months is going by, and all of the services and organizations that you see in this picture, we came in contact with. The first neurologist that my father saw did not believe that an MRI was necessary, and he saw nothing noteworthy. My dad did something called an MMSE. That's a mini mental state examination. He scored 27 out of 30. 24 actually is what you need in order to receive continuing, he's got normal cognition, I'm sorry, and he did very well, but he missed 3 out of 3 of the short-term memory questions, but nothing was alarming to him. But my mom kept pressing, and she said, we need to find out what's going on, and she refused to just take that at face value. The second neurologist that my mom saw recommended an inpatient dual diagnosis for alcohol and continued psychological psychiatric outpatient. My mom said that is not what's going on with him, and she continued to persist. They, in fact, finally got an MRI based on the fact that my dad was having hearing issues. And so they used a loophole to be able to actually get it done. What they found was significant frontal lobe degeneration, and they call that lobe atrophy and chronic small vessel ischemic change. But the way my mom learned about this wasn't the doctor giving her a diagnosis. This is the second neurologist my mother saw. That particular doctor actually came in, handed her a piece of paper, had the MRI up on the screen. After giving her the piece of paper, left the room, never to return. She did not receive a diagnosis from the second neurologist. The BVFTD, which is behavioral variant frontotemporal dementia diagnosis, finally came in February 2017 on Oahu. The same day of my dad's diagnosis, my father attempted to jump out of the 9th floor of a hotel in Oahu in the middle of the night. He was delirious. He did not understand that the sliding door, which had locks on it with no balcony, was not the way to get to the bathroom. My 105-pound-ish mother did everything with all her might to pull him back, even though he was able to get the window to unlock. This happened twice. Hotel security came up, and yet that was it. So she took him back to Maui. I want to stop there and just tell you, if you look at these names, and maybe you're on here, maybe what you do is actually on this list. Think about it from the plight of a caregiver. If you have a caregiver, my mom was hung up on quite frequently by 911. My mom begged law enforcement at times to understand what was going on. A diagnosis did not change the way she was dealt with. In fact, if anything, it made it very difficult. So for a moment, I want you to perceive the plight of the caregiver. This is a ridiculous level of stress, and you're in a state of constant and unimaginable stressful scenarios, day in and day out. I was hung up also quite frequently on the non-emergency line called emotional. I think you might be emotional too if you believe the things I'm going to tell you. Trying to jump out of a moving car and crossing 5 lanes of traffic. How do I not get emotional when I call you? Trying to jump out of a hotel room, also very emotional. A lifetime ban from Costco for stealing alcohol, another reason to be emotional. The challenge that I have with the systems and the people and the organizations that we had to come in contact with is that it wasn't simply being able to call and ask for help. We had to explain ourselves. We had to start off with, he has frontotemporal dementia. If I say Alzheimer's, you're probably very aware of what I'm asking. I'm telling you as somebody with a memory issue. But you don't potentially understand what it is like if you're calling and you say this particular dementia. And as a result of it, when seconds count, it takes infinite time to get help. And even if you're asking, that doesn't necessarily mean you're going to get help. I'd like to share just one more story with you, because you're getting a beginning of a story about my family and my dad, but it's not just us. And I'm going to have to read this one because the gentleman in the middle picture, actually, the young gentleman here is Justin Allen Davenport, and I've been given permission by his mom to share their family story with you. Justin Allen Davenport was born on September 13th, 1983, to Wesley and Robin Davenport. Justin met the love of his life, Jennifer Davenport, and was married in June of 2005. Justin and Jennifer became the parents of Haley Grace in December of 2005 and Ruthie Mae in March of 2007. Justin and Jennifer worked very hard to provide for their family and enjoyed many wonderful family activities together. Justin worked in construction, truck driving, and limestone mining. He also had a side lawn maintenance business, and he started attending Dalton State College and working toward a degree in business. Around 2014, 2015, they began to notice some changes in Justin. He began to be distant. He attributed this to his very busy schedule of working full-time in the mines, going to school at Dalton State, and having a side mowing business, assisting with building a new home for his family. And all that goes into being a father and a husband. As time went on, his wife began to notice he wasn't talking very much, and he would disappear for periods of time. While building the family home, lots of family issues began to surface. Justin continued to distance himself from others, and he started exhibiting some anger that they'd never seen before. Justin had always been a very passive person and very easy to get along with. Several people noticed that Justin was not talking very much. As time progressed, marital issues continued to surface, and in the summer of 2016, Justin and his wife separated. This triggered more aggression and very unusual behaviors. Justin was fired from 2 jobs for his aggressive behaviors, which is something he had never experienced before. To make a very long and painful story very short, Justin was arrested 4 times, 10-13 to 2 different stabilization units, spent 9 months in jail, 3 in isolation cell, and finally 10-13 to Georgia Regional Hospital in December of 2017. During this time frame, he was misdiagnosed with major depressive disorder and schizophrenic disorder. He was on the forensic unit at Georgia Regional Hospital, where his amazing psychiatrist recognized that Justin was not experiencing schizophrenia, but he was appeared to have a brain disease of some kind. His doctor suspicions, but he appeared to have a brain disease, and he got an MRI in April of 2018. The outcome was brain atrophy. The diagnosis was a sort of frontotemporal degeneration. Justin remained until recently in the forensic unit at Georgia Regional Hospital, where he received excellent care. He has since transitioned to a skilled nursing unit. There are huge barriers in the transition due to his age. Facilities who specialize in dementia are private pay, starting at about $4,000 per month. I'm going to, at the end of this, tell you the rest of my family story and where they're at today, but I will say right here that my parents pay, or my mom is paying right now $26,000 a month out of pocket to ensure that my father has care, and he requires round-the-clock, one-on-one companion. The facilities that accept Medicaid and Medicare told them, the family of Justin, that they cannot provide the support that he needed due to his age. This is actually quite common. God ensured, as Justin's mom says, that his needs were met at the Georgia Regional Psychiatric Hospital, where they have an amazing staff providing excellent care and implementing therapeutic services, and a high staff ratio that Justin can receive and cannot receive in a skilled nursing unit. He's now cared for at home by his family. I want to just say that this is really hard for me to say now, but I'm going to have to say it. Justin's family and my family were actually quite fortunate. How can you say that we're fortunate? Well, I'll explain. The Association for Frontotemporal Degeneration has support groups located around the United States. The very first one that I went to, we all introduced ourselves and we talked about our loved ones. And as we rounded, we found out there were business executives, there were physicians, there were business owners like my father, there were researchers, there were incredible people with this disease. And someone astutely pointed out that, wow, most of the people with this disease are professionals. How amazing. These executives and all these people with all these they're very intelligent. And it took me a couple minutes, but then it dawned on me, no, they're no more intelligent. They're just privileged. Every year, a lot of people are not getting the proper diagnosis for this particular form of dementia. 60,000-ish right now, as I understand it, have been diagnosed with this dementia. My family, fortunately, received a diagnosis, and I think we're lucky. We had great insurance, resources, education, and we haven't given up on my dad despite his relentless damaging actions and behaviors. My mom advocated tirelessly and continues to advocate tirelessly, just as Justin's parents have advocated tirelessly for him. But the reality is that it costs tens of thousands of dollars. Access to testing and accurate diagnosing is not available. And there are very few physicians who are qualified to give a diagnosis. It takes on people on average 3 years to receive a diagnosis. And they beg for help. The bigger problem that I see is that I have a new lens. I don't just see people on the street or in our jails as simply a black and white situation. I think, and I don't have numbers to prove it, that there are a lot of people unaccounted for, and they're slipping through the cracks, and they're not getting what they need. They are not regenerative or treatable from a rehabilitative standpoint, and they are palliative. And it's not psychological, it's neurological. And there seems to be a gap. And that's really why I'm here today, was these are terrible, tragic stories, and they're painful to even share. I know that there are countless thousands out there who aren't getting any care whatsoever. And they're on our streets, and they're in our jails, and they are not accounted for. So I want to just stop there and say that prior to this, you may have thought of dementia as something of a disease for the aged, or you may have thought that it was a memory issue. But the reality is it's a lot more than remembering things or being old. And this is what unconscious bias looks like. I hope that after you hear from Dr. Miller, you will reevaluate your definition of dementia. I would like to now at this time introduce you to Dr. Bruce Miller. I'm honored to be able to have him present via teleconference today. Dr. Miller holds the A.W. and Mary Margaret Clausen Distinguished Professorship in Neurology at the University of California, San Francisco, where he directs the Memory and Aging Center. He is a behavioral neurologist who works in neurodegenerative conditions, emphasizing brain-behavior relationships and the genetic and molecular underpinnings of disease. He is the principal investigator of the NIH, the National Institute of Health, sponsored Alzheimer's Disease Research Center, and program project on frontotemporal dementia. Additionally, he helps lead the Tau Consortium, Bluefield project to cure frontotemporal dementia, and Global Brain Health Institute. He was awarded the Potemkin Award from the American Academy of Neurology and elected to the National Academy of Medicine. You may also recognize Dr. Miller from his appearance on 60 Minutes Bill Whitaker's report last May, entitled "The Cruelest Disease You've Never Heard of, Frontotemporal Dementia." Please join me in warmly welcoming Dr. Miller via the University of California, San Francisco. Thank you, Dr. Miller.
Thank you, Melissa. Should I do that again? Yeah. Thank you, Melissa. What a moving story. And I think you have told a very tragic story about a loved one who was taken away from a loving family struggle to keep this individual safe in the setting of a horrible degenerative brain disease. And your continued work in this space is truly admirable. And I can't tell you how honored I am to be with you in this discussion. So I am going to talk today about the disease that Melissa so eloquently shared with you. This is frontotemporal dementia, or frontotemporal lobar degeneration. At one time, it was called Pick's disease. So this is a very important neurodegenerative disease that I think has been overlooked, understudied, and I think with tragic consequences, as you've heard from Melissa Fisher today, for the individuals afflicted by this illness and by the families that look after them, the caregivers. So I'm going to briefly talk about how we think about this disease. I know you're lawyers involved with the legal system, but I'm going to try to keep the molecular story and pathology story understandable, and tell you how we think about these diseases. Well, I think this is important, as I think we're on the verge of powerful therapies for the frontotemporal dementias that I think if we don't understand the molecules and the genes responsible for the stories that Melissa shared with you, our treatments will be ineffective. I'm going to touch on the burden of caregiving. I could not do it more eloquently than Melissa did, but I'm going to talk to you about why this particular illness is particularly hard on loved ones, because it hits at the very centers in the brain associated with empathy, emotion, addiction, judgment, and this is why the manifestations that you've heard occur. And then a little bit about what we can do in the community, what we can do if we have someone afflicted by a condition like this to intervene and be effective. So I'm going to just give a couple technical slides and tell you how we think about these degenerative conditions. So whether it's Alzheimer's disease, Huntington's disease, Parkinson's disease, these are all degenerative diseases. They don't start at birth. They happen often in middle or later life. They all cause degeneration in different parts of the brain. We have genetic forms in frontotemporal dementia. We think approximately 15 to 20% of people have a gene. Imagine that, a gene that is responsible for the sorts of behaviors that Melissa described. But we also have many sporadic forms, which I think is the case in Melissa Fisher's family, where as hard as we look in the gene, even doing whole genome assessments, we can't find any risk for this degenerative disease. One of the exciting stories here is that we now have ways of studying these diseases in different model systems. So you can take cells from a patient with this form of dementia, the genetic form, study them in cell culture, knock them into worms, knock them into fruit flies, knock them into mice. And what we see in all of these different models, and we see the same thing, and I think in the human condition, is 3 stages of illness. The first stage is when bad proteins begin to aggregate. This is preclinical. As I'll come back to, we think most of these diseases have a preclinical phase where bad proteins are aggregating in the brain that goes on for at least 10 years and sometimes as many as 20 years. Preclinical, because even though the bad pathology is beginning to emerge, we have no clinical evidence. In the case of the brain, that means not enough neurons have been injured to cause any clinical syndrome. The next stage, and this is true in all of the models and in humans as well, is early symptomatic. What happens here is that enough neurons are injured in frontotemporal lobar degeneration, enough neurons in the frontal lobes are injured that we're beginning to see a syndrome of some kind. In Alzheimer's disease, we call this mild cognitive impairment, and it's associated with memory. Why memory? Because that's where these bad proteins hit in the brain, in our memory centers. What is the early symptomatic phase of frontotemporal dementia? It's exactly as Melissa described. It's behavioral, it's psychiatric, it's addictive. These are brain regions that are affected, that are involved with the modulation of our behavior, our drive toward things that we shouldn't do. So almost all of the people that we see are seen first in the jails, by social workers, by HR systems where someone is not doing well. Sometimes it's a marriage counselor. Sometimes it is someone involved with thinking about why this person is not doing well in their job. So this early symptomatic phase of frontotemporal dementia is very different, as we've heard, from really almost any neurodegenerative condition. And then finally, the full-blown dementia syndrome. People are profoundly impaired behaviorally. They start to develop abnormalities in movement. And no matter what we do, and this is true of all the degenerative diseases right now, all of these conditions in 2020 are still fatal. This is a horrible tragedy. We lose elders in the case of Alzheimer's disease because of this tragedy. In the case of frontotemporal dementia, we even lose young people in their 30s, 40s, 50s. The story is really fairly simple. Misfolded proteins aggregate in a specific circuit in the brain. They spread from one cell to the next. It's all about the geography of the disease. Where these bad proteins aggregate determines what the behaviors are. So all these illnesses, Alzheimer's disease, frontotemporal dementia, progressive supranuclear palsy, cortical basal degeneration, Parkinson's disease, Lewy body dementia, multisystem atrophy. These are all degenerative conditions, each one of them associated, as you can see here in this slide, with different proteins. And when these proteins misfold, they cause injury to neurons and the cells surrounding neurons, the glia, which leads to this progressive degenerative process. What about frontotemporal dementia, the illness that you've never heard of? Thank goodness for people like Melissa who want this story told. When I was growing up in neurology, we were told, don't pick Pick's disease. It was a bit of an alliteration. The point was, this is so rare that you'll never see a case. We can't differentiate this from Alzheimer's disease. We shouldn't be thinking about abnormal behaviors, which is really what Pick's disease was described at that time. It just was ignored by neurologists. It was ignored by psychiatrists. Yet, I think we have learned you should pick Pick's disease. It is a common dementia. In people between 45 and 64, it's as common as Alzheimer's disease. It's the most common cause for neurodegenerative disease. It causes dementia in people under the age of 60. And I think even more striking, I've listed diseases that maybe some of you have been familiar with a loved one or a friend or someone that you know. But Lou Gehrig's disease, or ALS, progressive supranuclear palsy, cortical basal degeneration, CTE, the disease of football players, I'll come back to that in a second, are really so strongly linked to frontotemporal dementia. I think if we had a treatment for one of them, we would have a treatment for all of these diseases. I also would emphasize that we're learning more and more that at least 25% of our cases happen after the age of 70. So this is not just in the young people that Melissa described, but it also is common in people over the age of 70 as well. We think in the US, this would be classified as an orphan disease, about 60,000 cases listed, but this is almost certainly an underreporting. Many cases, if they don't have the kind of family that Melissa described, never get diagnosed. They end up in prisons, they end up in mental hospitals, they end up homeless. And this is really the tragedy of a degenerative disease that presents behaviorally. A lot of these people are never, ever recognized. So I'm not going to belabor this slide, but I think for me it's a startling kind of story. So we have three major subtypes of frontotemporal lobar degeneration or frontotemporal dementia. I'm going to talk about the behavioral form, which you can see here affects the right side of the brain more than the left. Isn't that remarkable? A degeneration in the right frontal lobe presents as a behavioral disorder, as a psychiatric one, whereas a degeneration on the left side of the brain, the semantic variant or the non-fluent variant shown here, they're easy to recognize. This is a language disorder. We recognize this, and this is the left side of the brain. So I think one of the remarkable things about frontotemporal dementia is not only is it important disease in its own right, but it's really beginning to help us understand how the brain is organized, why we see deviant behavior, why we see people who show behavioral disorders. I think it gets at the anatomy of these conditions, whether it's frontotemporal dementia, schizophrenia, bipolar illness. These are all disorders of the prefrontal cortex, right more than left. Okay. This is an important study done by the neuropathologist at Boston University, Anne McKee. And the punchline here is the areas that you see here in the brain with abnormal aggregates of brown are the anterior temporal lobes, the amygdala, an area involved with emotion. And in this football player who died undiagnosed, what you can see here is there is massive degeneration of the frontotemporal region, and there are huge involvement of neurons with the tau protein. So like the frontotemporal dementias, this is a disease that begins in the prefrontal cortex, spreads out across the brain, presents as a mood disorder, an addictive disorder, and sometimes as a behavioral disorder where people do violent things. And one of the reasons we know so much about this condition is that it predisposes to profound mood alterations. You heard the story that Melissa described of her father thinking about jumping off a building. Many of these football players' brains come to Anne McKee because they've committed suicide. So just a point of view of the research that we do in this condition. So as I pointed out from the early slide, there is a preclinical stage when people are asymptomatic. We think it goes on for about 15 to 20 years. What we see during this stage is very, very slow, if any, indication that there is a degenerative process going on. During this time, bad molecules are starting to aggregate and spreading along frontal temporal circuits. About 5 years before the diagnosis emerges, we start to see in the blood the evidence that with the protein neurofilament that neurons are degenerating in the brain and being released into the brain and the blood. We think this is going to be a very, very good blood marker for following treatment trials. Then, and I think Melissa really described so eloquently this questionable stage, the early stage, early symptomatic stage of these degenerative disorders, where the only thing we really see are behaviors. It might be a gentleman who loses interest in work, becomes apathetic. It might be a woman who is becoming abnormally compulsive and doing ritualistic compulsive behaviors over and over again. It might be someone who becomes addictive and suddenly is over drinking. So this early stage of frontotemporal dementia is very slippery, very hard to diagnose. And I think having lawyers and people involved with the legal system aware of this early stage is going to be very important for society. And I believe when we recognize these people in the early stages, we will soon be able to treat them. Then becomes the degenerative process. Some people think it may be too late with the drugs that we're working on today, but I think the degenerative process is the tragedy that unrolls over a family, over a community, and I'll say a little bit more about this in a few minutes. So this is what we know about Alzheimer's disease. The same is absolutely true in frontotemporal dementia. Very few symptoms until a period of 4 or 5 years before someone is becoming symptomatic. In Alzheimer's disease, we already have incredibly good biomarkers of people 15, 20 years before they are likely to get sick. This is happening in frontotemporal degeneration as well. And then finally, there's the degenerative stage, which may be, I think, too late when we start to think about really powerful, effective therapies. This is the case of Alzheimer's disease, 15, 20 years before someone is actually going to get clinically sick. We start to see this bad amyloid protein in the brain. Soon after that, the tau protein begins to aggregate in the brain. And these bad molecules that are causing degeneration in specific brain regions spread and spread out without many symptoms. So I think this is where we have outstripped our treatment abilities with diagnosis. And the same is beginning to happen in the frontotemporal dementia as well. We call this biomarkers. We need really good biomarkers so that when you see someone in your law office who is exhibiting for the first time in their life antisocial behaviors, it would be incredibly important if we could say, yes, this is happening because there is a degeneration in the prefrontal cortex. We're very, very close to that stage. So misdiagnosis, you heard it again and again from Melissa. In our behavioral variant frontotemporal group, you can see if you were a woman and you were starting to develop these behavioral or addictive syndromes, 70% of the time, with firm conviction, someone diagnosed you wrongly as having a psychiatric condition. Indeed, a full 50% of these individuals, and I would say it's not hard to diagnose. I would say it is every bit as easy to diagnose as Alzheimer's disease. It's just that we have ignored, neglected this disease, and it goes, I think, somewhat contrary to beliefs in society that behaviors are fully our own responsibility and somehow are dissociated from the brain. I think as we learn more and more about the brain, these ideas will slowly disappear. But look at the non-fluent patients. When you have a language disorder, people recognize this. This is not psychiatric. So this is, I think, the story of misdiagnosis. And I'm quite sure that in the Northwest, we are getting better and better at recognizing these patients early in their illness. So I think we all think about Alzheimer's disease. Probably everyone hearing this talk has had someone in their family or a loved one diagnosed with Alzheimer's. I think very few of you have thought about frontotemporal dementia. But I think, as Melissa and I would argue, equally important and also very, very prevalent. Difference, it's a behavioral disorder. The research criteria require disinhibition, apathy, emotional blunting, loss of sympathy and empathy for family members, loved ones, animals, obsessions and compulsions, mental rigidity, sometimes a mood disorder, sometimes apathy, misdiagnosed as a mood disorder. Alzheimer's disease does not usually present as a behavioral syndrome, and it doesn't present in this wild behavioral disorder that you heard about from Melissa. So much more subtle, sometimes depression, sometimes a little agitation and irritability, but not this full-blown behavioral syndrome of frontotemporal dementia. Cognitive disorders are also different. Frontotemporal dementia presents with what we call executive dysfunction, and if it's on the left side of the brain, it presents with a language syndrome. Executive dysfunction, trouble organizing, planning, generating ideas, decreased creativity, problems with starting and then stopping. So these are cognitive deficits that are very different than the memory loss, visual spatial impairment, executive loss. I just have to tell a quick anecdote around this. I recently was talking with one of my psychiatric colleagues here who spent time during her medical school training at UCSF, and her father, a very distinguished engineer, has developed frontotemporal dementia. He spends, after his wife died, he had no interest in her funeral. He stayed at home, no interest, totally out of character, and began to go online to look for a new wife within days of his wife's passing. He came out to the Washington area, found a new wife, married her within 2 days, and the bank account was beginning to disappear within a day. After going home, he found and this marriage was annulled by the courts. He found another wife in Lithuania, same story, walking the streets during the middle of this COVID epidemic, unwilling to agree that he has any cognitive impairment. Just as Melissa inferred earlier, he had cognitive testing, and because he didn't have memory loss, a very competent psychologist argued in the courts that he did not have a dementia because he didn't have memory loss, and said he should be allowed to manage his own affairs. So with this idea, this man will be dead within a month or two because the person does not understand the manifestations of frontotemporal dementia. So what do we see early? What is this preclinical state like, or early clinical? Selfishness, passivity, addictive behaviors, sometimes multiple addictions at once. Alcohol, cigarettes, food, sexual addiction, all happening at the same time. Disinhibition, criminal behaviors. I'll come back to that in a minute. Some of the most compelling and saddest stories happen around loss of empathy for others. Why does that happen? That happens because the part of the brain that allows us to feel what other people are feeling, to understand what other people are feeling, is hit very early in frontotemporal degeneration, psychiatric syndromes, particularly in the prodrome. Okay, I'm going to show you just a few anatomy slides because, well, I'm a neurologist and I love anatomy. I can't resist it. But I'm going to give you an example. So this is the orbital frontal cortex, part of the brain that used to be ablated with the prefrontal leucotomies. Sometimes it was partial, sometimes it was complete. Often with very bad behavioral outcomes. But we've learned recently that this is an area that's very critical for reward. So let me give you an example. The medial orbital frontal cortex connects right with the hypothalamus, which tells us to eat and or not to eat. So you put someone in an MR scanner, ask them to eat a chocolate when they're hungry. What happens is this whole medial orbital frontal cortex lights up. Second chocolate, the same. The third chocolate, the same. By the time the 8th or the 10th chocolate has been eaten, they're starting to get a sense of fullness. This is not pleasant anymore. I'm not enjoying this whatsoever. We've all done this at a meal. We've all done this shopping. The first jacket was fun. After we've bought 15 or 20 jackets, we're starting to think about not feeling too good about the bill that's soon to approach us. So what happens when we start to feel full is this orbital frontal cortex medially starts to downregulate. And what happens is this lateral orbital frontal cortex and the anterior insula, all part of the frontotemporal circuit, begin to activate. It says, stop, this is too much. This is not good for me. These are all the internal signals that the frontal cortex takes to say, I should not continue this addictive behavior. So imagine a degenerative disease that sweeps across this region, disrupts it entirely. What we see are people who spend massive amounts of money. In fact, it's not rare to see someone go bankrupt in the early stages of frontotemporal dementia because spending that money is rewarding and there's no signal for punishment, danger, be careful. The same is true with alcohol, cigarettes, marijuana, all of these things that these individuals start to crave. We think about 50% of our patients develop overeating or some other form of addictive behavior as an early manifestation. I want to show you an individual who has 3 manifestations of frontotemporal dementia. And I also like to say some of these diseases are diagnosed in situations where we have very strict social regulation. So church, places of worship, lectures, elevators where people are crowded together, funerals where we have to say the right thing. These are places where patients with frontotemporal dementia don't follow the rules. They're disinhibited. This gentleman would spend all of his time during church service, which I'll show you in a minute, if he wasn't regulated, eating all of the cookies that were there for after the church. So he's overeating. He's got a compulsion that he can't stop to give people back rubs. If you get in an elevator with Bob, he will give you a back rub. For those people who are comfortable with this, it's okay, but you'll see in church, this is not so good. So he's also quite disinhibited. So here's his incredible wife talking about him in church.
We never go the first Sunday of the month because that's communion. In our communion, you walk down front, and as you walk down the aisle, everyone was greeted and back rubbed and asked where they were from, which is very disruptive.
Africa.
Okay. Imagine putting a gentleman like that in a legal system or putting them in jail. It happens. It happens. Okay, so a little bit about crime in frontotemporal dementia. This paper I did with a number of different people across the world. Madeleine Liljegren and Elizabeth England are in Lund, Sweden. George Nassan is now in New York at Mount Sinai. We did a study here, and the punchline of this study is that almost 40% of our patients with behavioral variant, just as Melissa described, committed an antisocial behavior that either led them to get arrested or could have led them to be arrested if they didn't have a family around them to protect them. So this is far higher than any other degenerative disease. The only one that comes close is this temporal lobe variant of frontotemporal dementia called semantic, where there is a compulsion to put things in one's pocket. So almost all of those individuals ended up getting arrested for shoplifting. Alzheimer's disease, we had a few of our 500 people that committed an antisocial behavior. Unlike the behavioral variant people, this happened in the late stages of the disease when they might have hit somebody in their home, a caretaker, where they had really profound dementia. Behavioral variant, again, this is why I think it's so important to be talking to a legal group. This was sometimes the first manifestation of this illness. So something to think about. A crime in someone in their 40s, 50s, or 60s who was well behaved before this happened, who had never committed antisocial behavior like this. A silly antisocial behavior with no planning or forethought. I think all of you should be thinking about the behavioral variant of frontotemporal dementia. Another thing that Melissa touched on is this compulsion and sometimes loss of disgust. We've learned from our studies that loss of disgust is associated with degeneration of a specific brain area in the brain, that's insula, that's designed to protect us from doing things that might harm us, like eating spoiled food. Well, here's an example of Bob again with this behavior of compulsion, and see what you think when you watch this. Okay. So when we watch this, we feel disgusted because our insula is working. Patients with frontotemporal dementia eat food off of other people's plates, do things like collecting cans, drinking things off of the street. I think when you see that film, you might wonder whether this is someone who's part of our homeless population. And we are working on a paper now that shows that we have a number of people in my frontotemporal dementia program project grant who actually were homeless in the early stages of frontotemporal dementia. So again, I think Is this common among the homeless? No. Are frontal disorders common among the homeless? Yes. And I think if you have frontotemporal degeneration and you don't have a family like Melissa's, that is where you end up. Just want to say a little bit about empathy and the loss of empathy with frontotemporal lobar degeneration. So this is a nice paper by Kate Rankin, which showed basically that if you show unempathic behavior, as described by the caregivers, we've also quantified this looking at the patient in real life. You show atrophy in a very specific part of the brain, the right anterior temporal lobe. So this is the part of the brain that allows us to see how other people are feeling, to feel that internally, and respond to that appropriately. If that part of the brain doesn't work, we see profound loss of empathy, people not responding to the illness of a loved one, people laughing when others are hurt. This is a profound aspect of frontotemporal dementia, and it really alienates these people from others. And I think in the legal system, I think it can alienate them from juries, from lawyers, from judges. But I think without realizing that this loss of empathy is caused specifically by a degeneration in the right anterior temporal lobe, these people will not be managed properly. Few last things I want to talk about, and I think Melissa really set the stage for this, is if we don't have good functioning frontal cortex, we lose empathy. I've known for years, but finally we quantified this in a paper, that marital dissolution and infidelity significantly greater in BVFTD than any other neurodegenerative condition. So these are people who were loving husbands, wives, partners, who all of a sudden decide to have affairs, they're infidelities. And the other side of this is they become so unempathic that their partner can no longer imagine living with them. We decided in this study to look at where in the brain this was associated with. It was, again, very strongly associated with frontal lobe disease, and empathy loss itself was associated with marital dissolution. And in the BVFTD patients, not all of them experienced marital dissolution or infidelity. Those that did had lower empathy as well. So this is a degenerative disease in the brain that drives real life behaviors that have a huge impact on the people around them. Alice Waugh studied this with Bob Levinson at Berkeley. And we went about this, I think, in a slightly different way. Alice said, what about the patient's brain affects the caregiver? And so she looked at caregiver health and caregiver psychopathology. We've known for years that if you look after someone with Alzheimer's disease, about 10% of the time, caregivers say, excuse me, that they have, caregivers have suffered their own physical health issues. So we wondered about frontotemporal dementia. Here's the finding. Basically, if the patient had atrophy in the insula, the orbital frontal cortex, some other regions in the anterior prefrontal cortex, the caregivers did worse. So this is a way of flipping this around. Where in the brain this happens determines how well the caregivers survive. So is there anything we can do? Certainly we spend a lot of time thinking about caregivers. This is what Melissa does in Oregon. She spends time with the loved ones of these patients. And I think any visit with a physician or a social worker, psychologist, we must think a lot about the loved ones. That's the first. The second thing we've learned is even in the genetic forms of frontotemporal dementia, a nice paper by Caitlin Castellato, shows that if they participate in cognitive activities and physical activities like exercise, they progress at a slower rate than people who don't. So in other words, even in the most strongly, rigidly predictable forms of frontotemporal dementia that are caused by a single gene, the lifestyle that that person lives will to some extent protect them. They get the disease later. So what's coming in the next decades? Better diagnosis. I think lawyers, paralegals, people across social service system in our society are becoming more aware of frontotemporal dementia. We're finding new genes. We have big national efforts. And I think the first degenerative diseases that we will treat are those caused by genetic forms of frontotemporal dementia. So thank you very much for listening to me today.
All right. Well, I want to say thank you very much, Dr. Miller. You have been a profound support to not only myself, but for all of us out there who have been touched by this disease. And I would like to say, I'm speaking on behalf of a lot of people right now who want to say thank you very much for your tireless work and picking this disease. I have an enormity of gratitude for that. And one of the things I want to say that I learned after a few years of this is that while my father was the one who received the diagnosis, we all have this disease. One person is the diagnosed, but yet we all have it. That's a very unique situation. And I want to just say thank you to you and your entire team, and for everyone out there who's working towards improving things. I also want to say one last thank you to the people who shared their family story, Justin's family, as well as those who shared pictures that I presented at the beginning of this presentation. And then lastly, I want to thank my parents. It is really hard to think that I am looking at something that I didn't ever dream we'd be touched by as a family. My father never committed any crimes in the first 70 years of his life. He never got in trouble. So I was going to share with you just where things are at for my family. And I know, like I said at the beginning, this is very different for everybody. But the heartache continues for our family after 3 years. My mom did the very best she could, and I hope when she listens to this, she knows that. She did everything she possibly could to keep my father home with her for as long as she could. At the beginning of February of this year, I went to Maui to help her put him in a care home. Not very simple because there really are no care homes out there that are capable of handling people with this specific type of dementia. The location he's at now is doing the very best that they can, but they are not adequate. What I want to add to that is back to the caregiver plight. Not only is it emotionally exhausting, but it physically destroys you. Case in point, a week after placing my father in the facility, I took my mom away for a little respite after years of taking care of my father. Our first morning at the resort I took her to, she fell doing yoga. She broke off the top of her femur, necessitating an immediate trip to the emergency room where she had emergency hip replacement surgery. I stayed with her for a week in the hospital, and then she spent the next 2 weeks rehabilitating in a care home run by the same organization where my father was, but in a different part of the city. I think that's quite tragic and ironic. Of course, then I had to return because of the disease or the virus that's going on right now. And I haven't been able to see her or my father since. Again, I'll say it, we're fortunate. It's hard to even imagine how fortunate we are. Because he's safe. She's relatively safe, but this is painful. And I don't want to ever discredit the importance of the people in the lives of those who have this disease, but recognize that it is trying beyond. And it's why so many people end up alone. So I have a passionate plea, more than just a next step, as I would encourage you to learn more about frontotemporal dementia and sign up to receive the Association for Frontotemporal Degeneration's information available at www.theaftd.org. I would also ask that you consider how frontotemporal dementia applies to your work. That can be healthcare systems, that could be mental, behavioral health organizations, that could be the justice system, first responders, both city, county, and state police. And think about it in a way on how you might identify areas of opportunity to include it in the design of your existing systems and new systems. Think about the processes, the policies, the protocols, because there is room. There is a lot of room. And when we more fully understand who we serve, we are doing better by them. I believe in dignified endings for all of us. There right now is very little dignity with this particular disease. I encourage you to advocate and share this information and this session with others. And if you want to do more, I also want to make myself available to you. I would love to help you in your work. So thank you again on behalf of myself and Dr. Bruce Miller. I hope that this has been an enlightening session and an opportunity as a catalyst to change. Thank you.